Hello, thank you all for joining us today. My name is Scott Leeser. I'm the Senior Vice President at Cure Strategies and helped lead the Honor the Gift campaign. CareDx sought to create a movement to address an injustice in Medicare policy for kidney transplant patients. This short-sighted policy caused many donated kidneys to be rejected, cost lives, wasted Medicare money, and failed to honor the selfless gift of organ donation. Our coalition, Honor the Gift, and the National Kidney Foundation and its 32 partner organizations organized and catalyzed the community. We wrote white papers, memos, one-pagers, congressional testimony, and op-eds. We enlisted the help of more than 11,000 patients, advocates, clinicians, many of whom are joining us today, as well as members of Congress for their support. We petitioned our case in front of hundreds of Hill staff, White House aides, committee advisors, representatives, and senators, and most of all, we elevated patients and their stories to convey the perils of this ill-conceived policy. Today's webinar represents a new era in post-transplant care, one where there is guaranteed access to immunosuppressive medications for the lifetime of a transplanted kidney. Now, before we get started, I'd like to cover a few webinar basics. So first, entering full screen will allow you higher quality video. You can use the chat to comment, and you can use the Q&A at the bottom of your screen to ask questions. Next, when chatting, you're going to want to click on all panelists and attendees, and you can do so in the chat function at the bottom of your screen. Here's a disclaimer that we include in all of our webinars for today. And lastly, it is my great pleasure to introduce today's moderator, Alex Harrison Flaxman. Alex is a two-time kidney transplant recipient and one of our patient advocates for the Honor the Gift campaign. She is also the patient advocacy and engagement lead at CareDx. Alex.
Thanks so much, Scott, and good morning, good afternoon to everyone from wherever you're joining us today. I see a lot of excitement in the chat, sharing where everyone's from, so keep that going. I am so excited to be here moderating this session today. As Scott mentioned, I am a two-time kidney transplant recipient myself, and I did have the wonderful pleasure to be a part of the Honor the Gift campaign, and it truly was just an amazing moment in time to see the passage of this bill finally happen after an over 2-decade fight. We have some amazing speakers lined up for today. We have Dr. Matthew Cooper, who is the Director of Kidney and Pancreas Transplantation at MedStar Georgetown Transplant Institute, and more importantly, one of the amazing Honor the Gift champions. We also are joined by Troy Zimmerman, who is the Special Projects Director of Government Relations at the National Kidney Foundation, and also an amazing Honor the Gift champion. And Mary Balaker, who is also a kidney transplant recipient and one of the many patient advocates who are part of the Honor the Gift campaign. And without further ado, we are going to kick it off with a legislative journey of the Immuno bill, because I think it's important to see how far we've come. And now we're going to kick it off to you, Dr. Cooper.
Hi, Alex. Thanks very much. So I want to welcome everyone myself. I first have to begin with an apology, as though it appears as if I'm sitting in my clinic. The truth is that I'm actually sitting in an airport about to travel to another location. But when this was planned, I begged to be a part of this because this has been so important to me. I'm now a transplant surgeon for 20 years. I direct the kidney and pancreas program at MedStar Georgetown. I've been affiliated with the National Kidney Foundation for many years, including being on their board of directors, and I've partnered with the team at CareDx on several projects. So my thanks certainly to the NKF, CareDx, and the Honor the Gift Coalition for not only their work in getting us to this spot, but also giving me the opportunity. I'm really the setup guy, and my purpose is to, in many ways, tell you about a 25-year-old journey, depending upon what seat you sit in, that has gotten us to this point. And it begins with what I think many who work in the kidney field recognize is that ESRD became an automatic condition for Medicare coverage back in 1972. And I think we all have to be appreciative and thankful for that. But in the course of directing that oversight and that payment, CMS, for some strange reason that we still have yet to understand, and as was introduced by Scott, just doesn't make sense, that really the payment for transplant was one, but the immunosuppressive medications would only be paid for 3 years following a successful transplant, unless the patient, again, reaches Medicare based upon age or is disabled. And I'm happy to say that kidney transplants certainly last longer than 3 years. And so while we solved one problem, we really appreciated that we created another. The first immuno bill was introduced in Congress in 2001, and Troy, who will follow me, will tell you that really the battle began and even get to that point, even many years prior to that. Next slide, please. To put this all in context and to assure we recognize what is a reality and required our attention, our tremendous attention, was some of the statistics that you see on the slide below. And I'll begin by saying I'm certain that these are a gross underestimation, and that 70% of U.S. Kidney transplant programs report patients having difficulties paying for meds, that Medicare patients may lose their transplanted kidney. In this study of a year 2015, that 375 Medicare patients identified coverage as being the reason for losing their graft. And particularly African-American patients were 62% more likely to experience graft loss than their white counterparts. Again, a reflection of the inability to pay for their medications, which is really unacceptable. And certainly, I think all of us on this call would say is something that we had to work hard to correct immediately. Next slide, please. Well, unfortunately, it wasn't immediately. So 20 years in the making, we were fortunate to get to the 116th Congress. You'll see some pictures here that I'll talk about under one of the bullets. But really what fueled the opportunity, quite frankly, was in many ways serendipitous. The Secretary for Health and Human Services, Secretary Azar, who many of you might know, whose father was also a kidney transplant recipient. And so this was something which was important to him and brought it to the attention of many in Congress that we needed to take an important look at this. We were fortunate and perhaps not surprising, whereas many things are somewhat divisive when brought to the floor of either the House or of the Senate. This really demanded and really found bipartisan champions in both the House and the Senate. Again, not surprising. We were fortunate, at least at this instance, to finally have the Energy and Commerce Subcommittee bring this to a hearing, which in itself was a true victory. I was fortunate and again very thankful to be an individual who represented the many patients, transplant programs, and families who donated the gift of life, to be able to testify before this subcommittee about the importance of this. And I'll tell you, and many of the folks you see on this call are also on the slide, we prepared for weeks my prepared testimony, some of which obviously was published, but also an effort to try and ensure that the answers to the questions or the testimony would be moving. And when it came down to it, at the time of the presentation, I remember using words such as, "This is nonsensical." I think I fell into my Dr. Seuss motif. And even the chair of that subcommittee encouraged all of the members to say, "We have got to get this done." And for, at the end of this committee hearing, we were very pleased to see that we really believe that we had gotten our message through and that this was potentially going to be successful for the first time in 20 years. But what was really the biggest, I think, impetus moving forward was the Congressional Budget Office's projected savings of what could potentially be a differential between graft losses versus lifelong payment for immunosuppressive coverage for the Medicare program. And most importantly, as was mentioned by Alex and Scott, a community of advocates who continued to be able to present their message to assure that, again, there was a recognition that this affected real people, real patients. Next slide, please. This is the data for the Congressional Budget Office. It's us in the business would say, well, we could have told you this a long time ago, but when the Congress themselves actually is able to look at the numbers and demonstrate, for instance, as shown on the slide, that in year 2030 alone, that there would be a reduction in spending of about 120 million, and over the course of a decade, in putting this together, that it would reduce direct spending by 400 million. Well, that was again I think the final push that allowed Congress to say that this had to get done because of the cost savings, in addition to what we think were real arguments that moved the folks that had heard from patients and professionals in the space. Next slide, please. And so we find ourselves in 2020. Many of us were actually experiencing this on a Zoom call. The comprehensive immunosuppressive drug coverage, hereby known as the Immuno Bill, was passed and was signed into law. But again, that date and time was not an immediate sort of turn on the switch, and it was recognized that it wouldn't be until 2023, which is coming fast, that this would add this new Medicare option to cover immunosuppressive drugs for kidney transplant recipients. There'll be some discussion in the question and answer period about why kidney transplants and what we could expect to follow. But again, I think this is incredibly exciting. I'm very pleased to have been a part of this, have given the privilege to testify before Congress. And again, I think this is a very exciting time. We look forward to 2023, when we can, I think, begin to say that we have really successfully defended a position which we think should have been changed many years ago. But again, we brought this through the finish line. And so I want to thank everybody for their opportunity, and I want to pass things off to my friend Troy Zimmerman from the National Kidney Foundation, who's going to talk more about the process moving forward. Thank you very much.
Thank you so much, Dr. Cooper, for fitting this in while you are at the airport about to board a plane. It really does show your dedication to the patient community, and we're so grateful for everything you've done. So thank you so much. And as he said, we are now going to do a little Q&A with Troy Zimmerman. But before we kick off that, Troy, why don't you share a little bit about yourself?
Yes, thank you for the opportunity. I've been with the National Kidney Foundation for more than 2 decades, and I've worked on numerous activities regarding increasing awareness and detection of chronic kidney disease, treatment issues, including dialysis and a variety of transplant issues. As Dr. Cooper said, I have worked for many years on the immunosuppressive benefit, as many of us have in the transplant community. In addition to the immunosuppressive coverage issue, other examples of other activities I've done in the areas of organ donation and transplant access include working with Congress to create a federal program to assist living donors with their unreimbursed out-of-pocket travel expenses. That's something that the National Kidney Foundation pushed about 20 years ago as part of the NOTA reauthorization. And I've also worked with other organizations in the transplant community to help advance kidney paired donations, because until that time, until Congress stepped up and clarified that kidney paired donations do not violate the National Organ Transplant Act, a lot of transplant centers were a little hesitant to do that. And as many of you know and are aware, it has really opened up some additional opportunities for living donation that otherwise might not have occurred. As far as this passage of this bill, the Kidney Foundation sees this as accomplishment as just one step towards making transplants more widely available to people with kidney disease. So we're very excited that this is enacted, and we're eager to move forward on some other initiatives in the coming years. So thank you, Alex.
Thank you so much, Troy, and again for all the efforts that you've made on all those initiatives. I know myself and all of the other patients on this call are very grateful for all the work that you've done at NKF. I do want to remind everyone that we are going to have time for open Q&A after this section. So please, I see some of you are already asking some questions, so keep those coming. So we're really just going to start with the basics. So the first question is, who qualifies for the new Medicare benefit?
Well, it begins with whether you qualify for Medicare in the first place. So this would be for people who are not aged and they're not disabled, they're not otherwise Medicare disabled because they already have permanent Medicare coverage. So it's for individuals like most of you on this call, or many of you on this call, who had Medicare based on their end-stage kidney failure. So you must have had Medicare Part A in effect as either the primary or secondary insurance the month that your transplant occurred. Even if you had other insurance that covered the cost of the transplant and therefore did not need to use your Medicare, so perhaps you had employer-based group coverage, you're still eligible for this new benefit if you do not have other insurance coverage, and as long as you had registered for Part A prior to your transplant. So again, you had to have had Medicare A in effect, but you didn't necessarily have to have used it as the payer of the transplant.
Great. That I think is a really helpful definition, because I know a lot of people are a little confused about, how do I know if I qualify? How do I find out that information? And then the other question we've seen a lot is it retroactive? Does the date of when your transplant occurred affect whether or not you can enroll in this program?
That's a good question. It does not matter when your transplant occurred. If it's been more than 36 months since your transplant, you are eligible for the benefit if you meet other conditions. So it could be somebody whose coverage ended 3 months ago, 3 years ago, 15 years ago. If you don't have other access to the immunosuppressive drugs, you can still obtain this new benefit. The enrollment began on October 1st of this year, and for anybody whose coverage has already expired, and the coverage is effective starting January 1, 2023.
Great. And January is just around the corner. So hopefully everyone started that open enrollment process, which leads us to our next question. How do I enroll? And do we have to re-enroll every year?
You do not need to re-enroll every year. As far as enrollment, if it's an individual whose 36-month post-transplant period is approaching, they already receive a letter from the Social Security Administration to remind them that their Medicare eligibility is ending. So going forward, this letter will now include information on the opportunity to get the extended immunosuppressive benefit, as well as instructions on how to obtain it. And again, the letter will explain that the medications are available only for people who do not have other coverage and who are not age or disabled, but it will provide information on how to contact Social Security to attest or verify that the individual does not have other coverage for these drugs. And you can enroll at any time. There's no penalty for late enrollment, and you might have coverage today and not have it tomorrow. You can always apply in the future if you have other coverage of the immunosuppressive drugs but lose it for some reason. So there's not any penalty for late enrollment. It's always open if your insurance status changes.
Perfect. And then also just to address a couple other things I've seen in the chat, we are recording, so you will get a copy of the recording, because I know that this is a lot of information that people are going to want to go over and share with others. So yes, we are recording this. And I also do just want to reiterate that this is only for kidney transplant recipients at this time. And then our next question is, what if my Medicare has expired, but I have other insurance coverage?
That's a very good question. One of the key aspects of this law and of the bill every time it was introduced in Congress, as Dr. Cooper said, it took a number of years. Congress designed the new law, the new benefit, as a coverage of last resort. So it's, as you said, Alex, it's only for kidney transplant recipients and only for those who have no other form of public insurance or private insurance. Examples of public insurance obviously would include Medicaid, also includes Department of Veterans Affairs coverage, includes TRICARE, which is for civilian armed forces personnel and armed forces retirees. And of course, private insurance could include things such as group health plans, an employer-based plan, or marketplace plans through the Affordable Care Act. So again, this benefit is for individuals who received their kidney with that Medicare eligibility, and when their 36-month period has ended, they would be able to get the extended Medicare Part B coverage for their immunosuppressive drugs only if they had lacked any other coverage, whether it's a public plan or a private plan.
Perfect. And then I am going to throw a little curveball, just because I know Dr. Cooper addressed this a little bit, but I think people are looking for a little bit more detail on why is it only for kidney transplant patients right now?
It's only for kidney transplant patients now because it's specifically geared for Medicare ESRD beneficiaries. And those are individuals who have Medicare only because of their kidney failure. So they're not Medicare aged, and they're not otherwise Medicare disabled or receiving Social Security disability income. So this is the category of patients that received special consideration by Congress for Medicare 50 years ago, where they became Medicare eligible regardless of their age because of their kidney failure. And by that, they were able to obtain maintenance dialysis or a kidney transplant regardless of their age. Any other Medicare beneficiary who had a kidney transplant, if they're aged or disabled, they already have lifetime coverage. So for individuals who are Medicare ESRD beneficiaries, regardless of their age, if they start dialysis and remain on dialysis, they have Medicare eligibility for as long as they remain on dialysis, or until they become aged and disabled. Then of course they'd be like other Medicare beneficiaries and have that lifetime coverage. So if they remain on dialysis, they have Medicare indefinitely. If they receive a transplant and they're not aged and they're not disabled, all of their Medicare ends 36 months post-transplant. What this bill does is simply extend Medicare eligibility after 36 months, but only for the immunosuppressive drugs.
Thank you for clarifying. You also just addressed several of the questions that were coming through the chat, so that was a very thorough answer.
That's good to know.
The other question we're seeing is, what are the cost premiums going to be? What is the deductible? What can people expect for out-of-pocket maximums?
The law established a formula for the monthly premium, and it's based on 15% of the cost of the combined beneficiary, so the individual's premium and the government share of the Part B premium for full Medicare coverage. And in September of every year, under the requirements in the law, the Secretary of Health and Human Services will determine the dollar amount for the upcoming year. For 2023, that will be $97.10 a month. So that is, again, 15% of the full Part B premium for other Medicare beneficiaries. Again, those beneficiaries, of course, have access to all Part B services. The reason this was limited to 15% is this law only provides coverage, extended coverage, for the immunosuppressive drugs related to the kidney transplant.
Thank you for that. And then the other question I'm seeing a lot is what will be covered and what won't be covered, because I think there's still a little bit of confusion about what does this actually apply to. I know it's only the immunosuppressant medication and just that, but maybe if you could provide a little more clarity.
That's correct. It's only for the immunosuppressive drugs. It does not provide extended Medicare coverage for any other medications that the transplant recipient requires, even if there are other drugs related to their transplant. It also does not cover necessary annual lab work and that type of needs related to the transplant. So I know there are multiple things that a transplant recipient must do to maintain their transplant, whether it's physician visits, laboratory work, as I said, other medications. It only covers the immunosuppressive drugs. The individual would still have a deductible they'd have to meet, and they'd still have a 20% copay, which is standard for Medicare Part B. So once they've met that deductible, which in 2023 will be $226. Once they've met that deductible, Medicare Part B will pay 80% of the cost of their immunosuppressive drugs going forward, and the individual would be required to pay the remaining 20% cost for each, and that's for each Medicare covered immunosuppressive drug. I know that a lot of kidney recipients take more than one immunosuppressive medication.
And again, you answered another question that I was going to ask. So thank you for being thorough. The other question is, do we need to have a supplemental policy alongside this?
Well, if you qualify for any other health insurance, like the examples I gave earlier, whether it's a private plan or a public plan, we would advise that the transplant recipient apply for that coverage, because that's going to be much, much more comprehensive than this benefit. Obviously, this covers only the immunosuppressive drugs. So, even if the cost of that coverage is higher than the $97 a month that the beneficiary would be paying, it provides a much more comprehensive coverage, which is, better for the individual's healthcare overall. And remember, if you're covered by any other public plan or private plan, you're ineligible for this new coverage. As I said earlier, this was designed by Congress to be a payer of last resort. And part of that reason was it helped keep the cost down. Dr. Cooper mentioned how the Congressional Budget Office estimated this would be a cost saver. And by doing it, and by limiting it to the immunosuppressive drugs only, we were able to get the legislation passed because it did not have a net cost to Medicare.
And then you kind of covered this again, but just to, continue to be thorough, because I think some of this can be a little bit confusing, is can people still have commercial insurance?
You can obviously get commercial insurance. If you're able to get commercial insurance, you should do that. You cannot have commercial insurance and get this benefit. As I said earlier, it's a payer of last resort. And again, it's a much limited benefit, obviously, compared to anything else that you might be able to get through Medicaid or through group coverage or anything like that. I want to also emphasize, if you're under age 65 and you're beyond 3 years post-transplant, you can get this coverage if you don't have other coverage. However, once you become age 65 or if you're disabled for other reasons in the future, you would be able to qualify for full Medicare again. So you would no longer need this special assistance, a special Part B extension, because you'd have full Medicare Part A and full Medicare Part B after you attain age or disabled status.
And then you touched on this a little bit, as you said, kidney transplant recipients, we do have to take a lot of immunosuppressant medication, sometimes multiple ones. So will this cover brand name drugs, only generic? Will it cover both, oral medication, injectable, infusions? How does that work?
Well, the transplant physician will be able to continue to prescribe the immunosuppressive drug regimen that he or she determines is most effective for that individual patient. I am not certain if the injectables would be covered. However, in comments that the National Kidney Foundation filed with the Department of Health and Human Services and Medicare prior to as this program was being developed several months ago, we did request that injectables be covered as well, and that is to be determined. I have not seen any updates on whether that would be the case, unfortunately.
Great. Thank you so much, Troy. I think we're going to come back to you with some more questions maybe here in a bit, but for this next section, we've gotten some live questions in the chat, and many of you submitted some questions ahead of time. So Scott, we're going to pass it back over to you for a minute. Troy mentioned this a little bit, but for those patients who are already on Medicare, do they need to do anything?
Yes, they do not need to do anything. They are already covered for immunosuppressive drugs under Part B. And so this is a program for those who otherwise would not qualify for Medicare. So they're not aged or disabled or have the ESRD benefit anymore. They'd be able to get the immunosuppressive drugs only through this benefit. But if you're already on Medicare, and this also goes for Medicare Advantage, because Medicare Advantage covers everything that traditional Medicare does, you do not need to do anything. Your immunosuppressive drugs continue to be covered under that program.
Great. And then for people that are already on Medicare and they don't need to do anything, to necessarily enroll in this program, does this change the cost of the drugs as it currently stands for those who are already on Medicare?
It does not change the cost of the drugs. The benefit remains the same. As Troy talked about, it is the premium plus the deductible of $200 and some odd, and then an 80-20 split, which is what Medicare and its 50 million beneficiaries already always pay.
And then for patients who have Medicare as their secondary insurance, what does that look like?
Again, and I don't think we can stress this enough. The program was set up as a program of last resort. So if you have Medicare, if you have another insurance, if you have Medicaid, if you have public insurance, TRICARE, basically the only way really to qualify for this program is if you are, falling through a safety net and there is absolutely no way to get your medications covered. This program helps provide that safety net, and it is anticipated to save 375 kidneys each year and $400 million over the course of 10 years.
Great. And then, so this question is a little multi-parted. So if I'm less than 3 years post-Medicare paid kidney transplant, but I know that I'm going to reach my 36 months in 2023, is this something that patients can preemptively start to enroll for, or do they have to wait until after that 3-year coverage has ended?
You should be receiving, as you are approaching your 36 months, and let's say you have no other coverage and you're going to fall off of Medicare with no other coverage, you will be receiving a letter in the mail from the Social Security Administration making you aware, one, that you are approaching your 36 months and what is the exact date of that, and then two, that this program is now available to you and you can enroll. The other thing that's important to note too is, let's say you need to enroll in this program. You need your medications covered under this specific Medicare beneficiary benefit. You can get that coverage. Then let's say you get other coverage later. You no longer need the Medicare immuno benefit. You can re-enroll at any time. So this is a drop on, drop off when you need it. Again, a safety net program that really helps ensure that nobody is left without at least some coverage option for these medications.
And let me add that in addition to that, Scott, that's a very good point. If you've enrolled and you're getting the benefit under the extended coverage, but you later obtain other health insurance beyond other than Medicare. So if you, for example, perhaps you obtain employer-based coverage through a spouse or through your own employment, or you sign up for an Affordable Care Act plan, any other coverage you get, you must notify Social Security within 60 days of that enrollment, and therefore you'd no longer be eligible. But again, as Scott said, if you're on this extended Medicare Part B after your 36 months ends, and then later you get some type of other coverage whether it's a public plan or a private plan, and then you lose that coverage again for whatever reason, you can go back on the extended Medicare program without any penalty or late enrollment or anything like that. So you can certainly go back and forth, but if you do go from this plan and then you, at some point in the future, you're not eligible because you've obtained other insurance, you need to notify Social Security within 60 days of that change.
And then Troy, while I have you, because you mentioned earlier that patients who are reaching that 36-month mark can expect a letter from Social Security about this and how to enroll and all of that. What about patients who are well beyond that 36-month? They're probably not going to get a letter. So what do they do?
That's correct. That's actually something that Scott will recall, and others. We had a lot of conversations with Congress about this because of the concern that it would be hard to identify those individuals and hard to reach them, especially somebody who, whose 36 months may have expired years ago. The Department of Health and Human Services will work with the transplant community, with the organ donation communities to help identify these people. They want to work with us as partners to reach out to them. So there are not any specifics that I'm aware of yet, Alex, but that is certainly something that we are all aware of, because it's very important to include those in this population who might be having difficulty accessing the drugs, and we want to make sure that they're aware of the new benefit and can enroll.
Great. And then Scott, maybe back over to you. We got a question, when Troy was talking about that this is only for those who qualified under the Part A for their transplant, whether it paid for the transplant or not, but they qualified, they had it. But, you're on dialysis, you're going through all of that, you're getting a lot of paperwork in the mail, and maybe patients don't know that they had Medicare. They didn't even know that that was something that they qualified for because, again, they used their private insurance. Is there a way for people to go look that up and see if that was a benefit that they had?
That is probably best suited for the Medicare helpline, being able to understand when and if you were on Medicare Part A. I believe we're going to be sending out a helpline with a recording of this presentation. And so it would definitely be a question best suited to answer on the Medicare helpline.
Perfect. And then again, just to reiterate, maybe you could help kind of redefine what coverage of last resort, like what that truly means, why this does not, help you if you have any other kind of insurance.
Yeah, it was, a lot of people lose coverage and become uninsured for many reasons. Maybe a job loss, maybe a change in your marital status. Maybe you are no longer able to afford more expensive coverage, and so you have to drop your health insurance. All of these are real scenarios that face not only everyday Americans, but also kidney transplant recipients. And so the intention here of this program really is to provide that safety net for those patients who lose coverage from other places and have nowhere else to go. And so by providing this, coverage, we're really able to, quote, honor the gift of that selfless donation, whether it be through a living donor or a deceased donor, and really help ensure the longevity of this transplanted kidney and prevent redialysis and retransplantation.
Perfect. Thank you. And maybe, just to provide a real story there, like you just mentioned, that's how I got involved with Honor the Gift. I had recently reached my post 3 years, and like you said, I wasn't working, so I didn't have access to employee insurance. I wasn't married, so I didn't have spousal insurance, and private insurance was just not an option for me to pay for. So I had no insurance and I could not get my meds, and it was, an out-of-pocket, very scary situation there for a few months. So I know that for me and many of the other patients on this call, and this is, huge, and I can't thank, all of you enough for being a part of this and seeing this, get across the finish line. It's really been a huge success and an honor to have been a part of Honor the Gift. And, with that, this is a perfect segue into our next speaker, who is both a very dear friend and also a patient advocate and part of Honor the Gift. And she's going to share a little bit more about, the patient perspective and how important this really is for us as kidney transplant recipients. So, Mary, over to you.
Thank you so much. It's really an honor to be able to be on this call today, and I'm so excited about this bill passing. And, like Alex has mentioned, what it meant to her and how scary it was. And that's exactly why I got involved with the coalition, is that I was in college and had my transplant, and that 3 years ended, and all of a sudden I'm in between getting a job and finishing college. And then I actually had a waiting period with the job that I did receive. I was very fortunate that, at the time I was able to receive not only credit cards, and that's actually how I paid for my medications. So I paid for my medications and I was $40,000 worth of debt because of those immunosuppressive medications to keep me alive. And so it became a very important aspect for me to be able to help others not to have to make a choice between choosing whether to eat or whether to take life-saving medications. So that's why I got involved. And this is just really an amazing opportunity for people to have that gap that we might have. I don't want to see people having to choose whether they are making a choice on their medications or food or gas in their car or caring for their children. So I think this bill is going to make a huge difference for those people that are really going to need some help and support.
Thank you so much, Mary.
I'm sorry. As being a 4-time kidney transplant recipient, I know what it means to be able to have that opportunity of those medications available.
It's so important. And then I think you have a couple ways for us to share this information with everyone.
Sorry about that. My dogs were barking in the background there. I think sharing the information for people is going to be really important. Sharing, this, not only the website and the recording, but also we're going to have a video as well. So I really hope that people have that opportunity to share it not only with other patients, that they might be able to help. And I think it's really important to share with everyone because you never know when you might have a gap in insurance or not having it available. And I think that's going to be very important, but also sharing it with your physicians, making sure that everybody is aware of this bill that has passed and as of January 1st and how many people will be able to help in the future.
Thank you so much, Mary. And again, just to reiterate what she just shared, we do want to make sure that you take this information to others because it is going to be so helpful. So we are, again, recording. So you'll be able to access the recording on our website. Ask your doctors if you have questions about coverage. Share this information with other kidney transplant recipients. And then also as a clinician, make sure that your staff is educated, especially the financial coordinators. They're the ones that are probably going to get the bulk of these questions that are raised. And, make sure your patients are informed. And then another thing I did see pop through the chat that I do want to just reiterate is that if you did lose coverage, and your transplant happened before the passage of this bill, it is retroactive. So there's not a cutoff date that you had to have your transplant by. So just make sure, that the information that you're getting is from, quality sources like Medicare, Social Security, National Kidney Foundation, because I know that can be a lot of misinformation and confusion out there, especially on a bill such as this. And then I want, more importantly, to give a huge thank you to the Honor the Gift Coalition. As Scott and Troy and Dr. Cooper shared, this was a huge group effort of 32 coalition partners, lots of patient advocates, lots of patient societies, lots of physicians, and it really, we wouldn't have made it this far without all of you. This has been an over 2-decade battle, and there's a reason that it finally happened now. It's this group effort and these amazing champions that we had behind us. So thank you to all of you that were involved. And now we are going to share a little video that was put together, when we celebrated the passage of the Immuno bill, to just really show, how many people were involved in this and the emotion that went into it. And I know, again, I'm so honored to have been a part of this. So thank you, everyone, for joining the webinar. I hope you guys found it useful. We will share the recording, and now check out the video.
11,000 Americans will die waiting for transplants this year. In the meantime, the Medicare program is putting people who are lucky enough to have a kidney transplant at risk by cutting off their coverage. Why do you think this has gone on for 50 years?
kidney transplant is an investment that the government makes into the patient's future. Unfortunately, that investment is lost, and the patient's health will take a turn for the worse if they cannot get their immunosuppressive drugs.
These patients were often forced to wait on a list for years behind thousands of people before finally receiving a life-saving transplant. However, many patients were frightened by what came next. Medicare only provided immunosuppressant drug coverage to most patients for 36 months.
Removing the 36-month cap on Medicare coverage for immunosuppressant drugs seemed like a no-brainer policy, but because of some budget rules and scoring from the Congressional Budget Office, it took a little while for people to open their eyes and also recognize the cost savings.
So after years, literally a decade of wrestling with the policy, a light finally shone over at the Congressional Budget Office, and they confirmed what others have known all along, that this delivers savings to Medicare.
It was interesting to watch this campaign develop. I mean, we've been around since 1987, so we've been here through the earlier campaigns and had the frustration of not being successful. I must admit, over the past year, there's been times I said, can this one be different? And I felt it could be.
Coming up, we're talking about Honor the Gift, guys.
Yeah, it's a campaign to protect the gift of life by removing Medicare's 3-year limitations on anti-rejection reimbursement.
The campaign was purposely designed to bring more people to that appreciation, to bring more people to the table, and to really to empower transplant patients to be able to use their voice in conjunction with the general community, because we recognize that this is a societal issue.
I feel like people had just given up on it ever happening, that it just wasn't going to ever get passed, so why put in the effort and the work? So I think CareDx really stepping up and saying, no, this is important to patients, and kind of, leading and paving the way, I think really made a huge difference.
Before I came to Congress, I really thought that Congress was a proactive institution. It's not, it's reactive. And so advocacy, the push from the outside, I think I know what to do on the inside, but the push from the outside is absolutely essential.
The passion that was there from CareDx and the Honor the Gift staff and all of the advocates that were involved, I just knew it was gonna pass. And so when it did in December, I was like, it just was just so excited.
More than anything, my first thought was, oh my God, I was a part of actual change. And to be able to say that I was a part of this amazing group of patients, clinicians, organizations, friends, family that enacted actual change for future generations to not have a battle that they have to fight is honestly, if that's the one thing I accomplish in my life, I'll be happy.
It will be such a relief for all of us to know that if something is to happen, we have something to fall back on to protect us and to protect this precious gift that we received either from a living or deceased donor.
So not only do we save lives, not only do we improve health outcomes, but it's also a better bargain for the taxpayer. You can't get better than that when it comes to healthcare reform. Advocacy works, but the best form of advocacy that I found throughout the years are those individual patients sharing their stories about what's happening to them with the status quo and what can change in their lives if we can adopt policy that makes better sense for them.
I want to thank the Honor the Gift Coalition's tireless advocacy in support of this legislation. Kidney recipients in Illinois and across the United States can rest assured knowing that you're looking out for them. I'm proud to have worked alongside you, and I'll continue to work to support your efforts for kidney disease patients in Illinois and across the nation.
Thank you so much for honoring the gift. This means so much to me and all transplant recipients and transplant recipients to be.